Dr. Samuel George Hanstek, sir, will continue to chair this segment also. I invite Dr. Vinay George David. Dr. Vinay George David is the professor and head of the Department of Nephrology, CMC Vellore. Sir has been awarded the Dr. Bronze Scholarship in Nephrology in 2007. Sir has published in Transplantation, Nephrology Dialysis Transplantation, and Peritoneal Dialysis International. Sir has been the co-investigator for global and multi-center clinical trials on kidney transplantation and chronic kidney diseases. Sir's area of interest include focus on hypertension, acute renal failure, kidney transplantation, and nephrology-related clinical trials. The next chairperson is Dr. Nisha Jose. Dr. Nisha Jose is Associate Professor in Nephrology at CMC Vellore. Dr. Nisha has authored and co-authored 11 publications in peer-reviewed medical journals. She's been awarded multiple accolades for academic excellence, including gold medals in nephrology. She has presented at conferences and CMEs. Her areas of interest are renal transplant, prognostication of acute renal injury, and medical education. Welcome, ma'am, and welcome, sir. The first talk in this segment is Integrating Renal Genetics into Clinical Practice by Dr. Suceena Alexander. Dr. Suceena Alexander is Professor and Head of Unit 3 in the Department of Nephrology at CMC Vellore. Ma'am is a Senior Fellow at DBT Wellcome Trust India Alliance and Associate Editor of the Indian Journal of Nephrology. Her area of interest is she serves as the Principal Investigator for the GRACE IgA nephropathy pilot study and supervisor for a project on immunoprofiling in focal segmental glomerulosclerosis. Today's topic is integrating renal genetics into clinical practice. Welcome, ma'am.
Yes, thank you for that kind introduction. Good morning to all my esteemed teachers, friends, and colleagues. Greetings from the Department of Nephrology. So the talk today that I'm delivering is on integrating renal genetics into clinical practice. This is a 20-minute talk, so I did have a lot of slides which I cut down for this session. The overall objective of this session is for you to understand the place that renal genetics now has in practicing nephrology. And as generalists, it does have an important role when you currently see your patients in wards or OPDs. As we all know, chronic kidney disease is an epidemic. It affects more than 10% of the world population. And inherited kidney diseases are responsible for about 70% of kidney disease and 30% of kidney disease in adults. 1/3 of adult patients with chronic kidney disease do give us a positive family history. And it is important for us to know that the early stages of CKD, that is stages 1 to 3, are asymptomatic. So we will get to know that either only by a screening evaluation, either through lab tests or by genetics. And this does have an impact on the prognosis of the patient. All right, so through the slide, I will take you through the various syndromes that we have commonly see in nephrology practice. And it will be a case-based approach where we will be giving you a few real-world cases that we have seen them in nephrology department. And most of the genetic work that is being done here is the bioinformatics. That is, the sequencing is done outside, and they provide us the raw data. But the entire secondary, tertiary, quaternary analysis, as well as the phenotype-genotype correlation, has happened in-house in the Department of Nephrology. Now, for this talk, we do know that there are two kinds of genetic diseases, which is monogenic and polygenic. But for this talk, we'll be concentrating on the monogenic disorders. It doesn't mean that the polygenic disorders are not important. It's just that we don't have the time to dwell in it. But suffice to tell you that important diseases like FSGS, membranous nephropathy, and IgAN can have a significant genetic polymorphisms that can affect its risk and prognosis. Oh, sorry, it's going back. Right, so this is a retrospective study which looked at all the cases in the tertiary center where the clinicians who were treating the patients suspected that there might be an underlying inherited cause for the kidney disease. And based on that, all the peripheral centers where clinicians suspected this, they referred the cases to the tertiary nephrology care, underwent a whole exome sequencing and bioinformatics. So the result was about 67% of them who had an underlying clinically suspected inherited kidney disease had a confirmation of the genetic diagnosis. 50% of them was an affirmation of what they suspected, and about 20% of them, the genetic diagnosis was modified. And when they looked at the cost effectiveness of doing an early genetic test in the clinical flow of patient management versus the standard of care, there was a significant difference in the health expenditure. Sorry, I'm going back. Right. And the way they went about this was they told the clinicians that this is a broad selection criteria. And if your patients had these selection criteria, then please refer. So the selection criteria was resistance to any kind of immunosuppressive treatments, a strong family history of kidney disease, any involvement that was extra-renal apart from kidney disease, evidence of congenital abnormalities of kidney ureter and bladder, at least 2 cysts in each kidney, persistent hyperechoic kidneys or nephrocalcinosis, and persistent metabolic abnormalities. When you look at adult versus pediatric, again, our normal assumption is that genetic disease is a pediatric disease, right? But I'm here to dispel that myth because genetic disease is very much adult disorder also. So if you look at the entire syndrome of kidney diseases, and if you look at the pediatric cohort versus the adult cohort, both of them had similar yields with regard to all the syndromic diagnosis apart from CAKUT. CAKUT obviously is a pediatric disease and it is picked up in the pediatric age group and very rarely it appears in adults. So the centralized workflow for the diagnosis of genetic kidney disease is feasible, efficient, and cost-saving. We also need to know that there are actionable genes that are related to kidney disease. Generally, when you speak of actionable genes, people generally think of cardiac genes or cancer-related genes. But there are genes in the kidney where if you take some action based on the diagnosis, it can change the management trajectory or the prognosis for that patient. So what are the certain actionable genes that we know of related to kidney disease? These are conditions that are amenable to specific disease-modifying therapies, and the examples are Fabry's, hyperoxaluria, steroid-resistant nephrotic syndrome, or cystinosis. There are conditions that are amenable to specific screening for extrarenal manifestations when you find that there is a kidney disease, like HNF1 beta causing diabetes, PKD1 and PKD2 causing intracranial aneurysms, as well as other renal cell carcinoma syndromes. There are conditions where you can actually avoid causing harm and avoid prolonged immunosuppressive therapy, especially in, for an example, is a steroid-resistant nephrotic syndrome, where the underlying genetic cause may be Alports, and you could effectively stop causing further damage by stopping the immunosuppression. Conditions that are at risk for recurrence after kidney transplantation, because if this patient has end-stage kidney disease and has a transplant, then we need to prognosticate it before he has the allograft. And some of these are atypical HUS, primary hyperoxaluria, as well as other inborn errors of metabolism. There are conditions where you can give non-specific renoprotective therapies like ACEs and ARBs, and which can significantly delay the progression to end-stage kidney disease like Alports, and conditions for which genetic testing is relevant for reproductive counseling for both parents and the child. Right, so as generalists, when you sit in the OPD and see patients, you need to understand that there are certain red flags that will help you to do the necessary referral for genetic test. So if you are aware of these red flags and then tick these red flags as you see the patients, it will help you to narrow down and enrich that population and increase the genetic yield in the population, in the patients that you are referring. So some of them are related to the personal medical history, and there's a significant role for family medical history. So in personal medical history, you'll have to look at the clinical presentation, whether there's any multi-organ involvement, whether there's any developmental history, any congenital anomalies that you're aware of, the rapidity of progression and the young age of onset, as well as a strong family history is indicative. Okay, now we are going to each syndrome, and I'll highlight these through a few real-world cases. So this is a syndrome where you have a kidney disease, but you don't know the etiology, and that's a very common cause for end-stage kidney disease. In this study, they looked at all the patients who had this kidney disease of unknown etiology, and they did a genetic workup, and they found that it spanned the entire syndromic classification, and the maximum yield was among glomerulopathies with COL4A3 gene involvement, as well as other genes that are involved in the nephrotic syndrome presentation. And the next common was tubulointerstitial and cystociliopathy syndromes. Right, so there's a 19-year-old boy who presented to us with nephrotic syndrome, that is hypertension, renal dysfunction, and proteinuria at 14 years of age. The kidney biopsy showed a glomerulonephritis. It was mesangial-proliferative glomerulonephritis. He was treated with multiple immunosuppression. There was no treatment response. There was a rebiopsy done, which again showed glomerulonephritis, but by this time there was significant amount of tubulointerstitial scarring, and he reached end stage by February 2023. When you look at his family history, he had, so this is a proband. He has a sister who also had a kidney biopsy, and her diagnosis in the kidney biopsy was anti-GBM with IgA nephropathy, and she underwent a renal transplant. He had a brother who died of probable kidney disease, and a father who died of probable kidney disease, and the mother had proteinuria. Any guesses? So what is the red flag here? The red flag here is there's a very strong family history, right? And the young age of onset. So those are the two red flags. So this is one case where probably you will refer them to a genetic and non-response to multiple immunosuppression. So all these are red flags. So we did a whole exome sequencing, and to no surprise, the diagnosis was Alport syndrome X-linked. Could we have predicted this from the clinical presentation? No, because it's a generic presentation of a nephritic illness. Right. The second case is an 18-year-old boy. Again, he presented at 18 years of age with renal dysfunction and hypertension. The biopsy was again suggestive of arterionephrosclerosis and CIN changes. He reached end-stage kidney disease. His elder sister also was a patient of ours, and she was seen 4 years earlier than this boy. And she also had an unknown CKD, and she had her father was her donor. So this was her younger brother who came to us at 18 years of age. Right, so this is the family history. So we did subject him to look in 2014. Renal genetics was not it was not very common for us to order for whole genome sequencing, right? So now renal genetics is a emerging subspecialty within nephrology, and there is it's become more and more common for us to pick up these red flags and order. So we ordered for this boy, and the diagnosis was nephronophthisis. It's an autosomal recessive disorder. So could this have been prevented way back in 2014? I would say yes, to some extent, because if we had picked it up at that time for her brother by giving cascade testing, we could have at least delayed her progression of kidney disease by giving non-specific renoprotective treatment. The next case is a 29-year-old gentleman. He again presented with proteinuria and renal dysfunction in December 2022. Renal biopsy was done, which showed significant chronic changes. He also did not have any family history of kidney disease. At that time, when we asked for the family history, he said it was a non-consanguineous marriage. But later on, when we asked him, probed him again, apparently it was an uncle to niece marriage, or his parents. His genetic diagnosis came to be Fabry's disease. Now, this is one thing that we all should remember, that Fabry's disease is a highly undiagnosed disease in our community. And there are a lot of people out there with Fabry's who would not come, like he did not have any other extrarenal symptoms. But when we probed, after we got the diagnosis, he did show us some angiokeratomas in the scrotal region. Okay, but he thought that was normal. He didn't think that was something that had to be brought to the attention of a doctor, of a treating doctor. Okay. Now, why is this diagnosis important? You know, there is an enzyme replacement for Fabry's, which is agalsidase. And if you don't give enzyme replacement for Fabry's, then actually you're decreasing the survival. You're decreasing the life expectancy by about 5 to 14 years for women and about 16 years for men. The next syndrome I'll be taking you through is genetics in nephrolithiasis or nephrocalcinosis or metabolic abnormalities. Again, it's a 17-year-old lady who has been having renal calculi, bilateral renal calculi from a very young age, from 5 years of age. He's had several urological procedures. She had a nephrectomy also. And she has a very strong family history of renal calculi. She's on dialysis now. She's come for transplant with father as a donor. Okay, so this is a very clear-cut case where you have a very strong family history. There is a sibling who's died of renal calculi at 6 months, and there is history of kidney stone on either side of the family. Because she was going for transplant, any guesses on the diagnosis here? Any guesses? So because she was going for transplant, we did a genetic, and it was hyperoxaluria. So this is something that we could have guessed from the history, right? By the fact that it was a very young age of presentation, and she had undergone recurrent procedures. We could have guessed this from the diagnosis. But why is it important for us to know what the underlying genetic disease is, what the underlying genetic mutation is? Here it is type 1 hyperoxaluria. That is, the gene that is responsible is AGXT. Now, we all know that there are three types of hyperoxaluria, right? There's type 1, which is AGXT. There's type 2, which is an enzyme deficient here is GRHPR. And there is type 3. Now, does knowing the genetic mutation alter the management? Yes. Because if it is type 1 genetic mutation, then many patients can even be managed with very high dose of vitamin B6. But vitamin B6 therapy will not be useful for the other two genetic mutation. Also, right now, FDA has approved 2 new drugs for the treatment of hyperoxaluria. They are all RNA interference molecules. They go by the name of lumasiran and nedosiran. And again, lumasiran is a molecule which will be useful only for type 1 hyperoxaluria, whereas the other molecule can be used for all 3 types of hyperoxaluria. So it is important. And with regards to transplant, if it is a type 1, because the enzyme is produced in the liver, it will not be a kidney-only transplant. It has to be a liver-kidney transplant. Whereas in the other cases, you can get away with just a kidney transplant. Okay, so this is the RCT which shows lumasiran. There was a significant reduction in 24-hour urinary oxalate in patients who had type 1 hyperoxaluria. This is another study where the clinicians in a stone clinic, they suspected that this patient could have an underlying hyperoxaluria or an underlying dense disease. Okay, so this was again clinically suspected cases. So all clinically suspected cases, they underwent a genetic analysis. And to the surprise of the authors, about 24% of patients who were suspected to have dense disease had some other etiology for their stone, some other genetic mutation for their stone. And about 8% of them clinically suspected to have hyperoxaluria had some other genetic mutation for their stone disease. Again, we cannot just go by the phenotype and say that this is the underlying genetic mutation. There can be significant heterogeneity. Now, genetics in cystic kidney diseases. The most common 2 genes that account for cystic diseases in adults is PKD1 and PKD2. But there are about 10% of cases who can have an alternate genetic diagnosis. And these are the genes that could be responsible for this. Even in a proven case of PKD1 or PKD2 mutation, the type of mutation, that is, when you sequence, you may have learned in your MBBS days about missense mutation, nonsense mutations, splice variant mutations. So there's something called truncating mutations and there's something called non-truncating. Truncating mutations, they truncate the protein. So it is dysfunctional. Non-truncating mutations, they just alter the function of the protein. It doesn't truncate the protein. So what the authors here have shown is that the prognosis of the patient over time varies whether it is, depending on whether it is a truncating mutation or a non-truncating mutation in PKD1 gene. The other common myth that we have is this is a disease of the adults. No, ADPKD is very well seen in pediatrics. It is not just a disease of the adults. In fact, there is a autosomal dominant pediatric kidney disease registry worldwide, which is going on. And it is recommended that asymptomatic children who are at high risk at ADPKD should be monitored for hypertension and albuminuria. There are a lot of other phenocopies. By what I mean by phenocopies is you have the same phenotypic presentation as ADPKD, but the PKD, but the underlying mutation may be due to other diseases. One example is a Birt-Hogg-Dubé syndrome, which again has multiple cysts that entirely replaces the renal parenchyma bilaterally, has pulmonary cysts, but the gene responsible is a gene called folliculin. It's important for us to know this because they have these skin lesions called fibrofolliculomas, which can turn malignant in future and needs to be monitored. There was a 45-year-old male who presented with hypertension and CKD, had ADPKD, reached end-stage kidney disease, and was being worked up for transplant. This is the family history where his brother had ADPKD, so he was out. He couldn't be considered as donor. He had a sister who was younger to him, but again, there were no cysts in the kidney, but because she was young, we do not know whether she will form cysts in future. So we did the patient, we noted that the sister was negative for this variant. So it was safe for her to go and donate the kidney for her brother. Now coming to genetics in nephrotic syndrome. Again, nephrotic syndrome can be classified based on the histology, which is usually minimal change, FSGS, or diffuse mesangial sclerosis. But none of them can predict the underlying causative mutation for nephrotic syndrome. Even based on steroid responsiveness, about 20% of pediatric cases and about 30 to 40% of adult nephrotic syndrome are steroid resistant. And out of these steroid resistant cases, about 30% of them in pediatric and a similar amount, and about 12% in adults have a genetic etiology. So almost all cases which has a genetic etiology are steroid resistant cases, though some may show some partial response. Most of the genes that are related to genetic mutations in nephrotic syndrome are related to genes in podocytes. They could be involved with lysosomal proteins or mitochondrial proteins, or they might be involved with slit diaphragm or GBM-associated proteins. I've highlighted all the other classifications, all the other classes here. And the inheritance pattern can be anywhere from autosomal recessive to autosomal dominant to mitochondrial. What if I told you that the minimal change disease that you were treating with steroid has now been classified as an autoimmune disease? Would you believe me? Yes, so times are changing. Minimal change disease, 1/3 of patients with minimal change disease have been found to have autoantibodies to a protein called nephrin. Okay, so they have anti-nephrin autoantibodies. So minimal change disease now needs to be considered under this huge group of autoimmune conditions. And this is an evolving algorithm for management of minimal change disease now. So in this, you can see that those patients who are anti-nephrin antibody negative in both pediatric and adult cohort, there is a role for genetic testing to find out the underlying mutation. So how does it help? Genetic testing avoids irrelevant immunosuppressive therapy. It helps in reverse phenotyping as in Neil-Patella syndrome. It helps us to offer cascade testing to affected family members and risk stratify, and it helps in prenatal diagnosis. What about genetics and congenital abnormalities of kidney and ureter? Again, mostly seen in the pediatric cohort. There is an increased risk of CAKUT among relatives. There is a multi-generational occurrence for this disease, and it is of both syndromic and non-syndromic forms. There are many genes which are responsible, but most of the genes are related to, most of the mutations are related to two genes. One is HNF1 beta and PAX2. Now, ADTKD, what do you mean by ADTKD? I mean, at least 5 years or 7 years ago, this term was not existent, okay? This term has come to existence only in the last 5 years. So ADTKD, the full form is adult autosomal dominant tubulointerstitial kidney disease. This is a new entity. It is a new syndrome in nephrology. And how do you clinically know that it is ADTKD? So everything that is the opposite of nephrotic syndrome. So you will have, apart from a positive family history, you will have bland urinary sediments. You will not have proteinuria. You will have normal sized or small sized kidneys, but it will be a progressive disease and you will have a family history. So if you have this, then you may have to suspect an underlying ADTKD. And the only way to diagnose this is by genetics. Okay, so there are two subtypes of ADTKD. One is by the U mode gene, and hence it's called the ADTKD U mode. U mode, as you know, is a protein which is expressed mostly in the ascending limb as well as in the distal tubule. The other one is a MUC1 gene. This is responsible for the mucin 1 protein. Mucin 1 protein is expressed through the entire distal segment. And here again in the algorithm for diagnosis of ADTKD, if urine analysis is bland, if there is no proteinuria, but there is significant family history, then you consider genetic testing. The other important subtype of kidney disease that you need to keep in mind when you look at, especially when you look at kidney disease of unknown etiology, is mitochondrial disorders. Okay, so we all know that mitochondrial disorders can cause stroke-like syndromes. It can cause a whole lot of eye manifestations. It can cause diabetes. But did you know that it can cause proteinuria? It can cause FSGS. It can cause tubulointerstitial diseases. And even kidney disease of unknown etiologies, some of the mutations are related to mitochondrial disorders. Okay, so some of my few concluding slides. The red flags, always remember the red flags when you are in your OPD. Extra-renal features, young age of onset, family history of kidney disease, and based on that, your yield for the various subtypes of kidney disease are given here. Cystic abnormalities, family history, young age of onset, extrarenal manifestations, and unclear etiology increases your likelihood of genetic diagnosis. And before I finish, this is an ICMR-funded project that we are running in the department, and we are able to give subsidized testing for the patients because of the funding that we have. And it's a collaborative project with pediatric nephrology as well as medical genetics. So if any of you are interested, please contact us. We are happy to collaborate. Thank you.
Thank you. Thank you, Suceena. Okay, we'll take the questions at the end.